Something happened in my clinic last year that I have not been able to stop thinking about. A woman came in with her adult daughter. She was 71 years old, sharp woman, retired school teacher. She had spent 40 years teaching children to read and write, and her daughter described her as someone who never forgot a name, never lost a thought in the middle of a sentence, never missed a detail. Until about 18 months before that appointment. By the time they sat across from me, she was repeating questions she had asked 3 minutes earlier. She was forgetting the names of grandchildren she adored. She had stopped driving because she got confused on roads she had traveled for decades. Her daughter had begun researching memory care facilities. They had both quietly accepted that something irreversible was happening. I reviewed her medication list. She was taking 3 common medications that most people, including most doctors, would consider completely routine. A sleep aid she bought without a prescription, a bladder control pill she had been on for 2 years, and an older antidepressant prescribed for mild nerve pain in her feet. We worked with her doctor to remove all 3 medications slowly and carefully over several months. 8 weeks after the last medication was stopped, her daughter called me. She was crying, but not the way she had been crying in my office. She was crying because her mother had called her that morning and talked for 40 minutes about a book she was reading. Because her mother had remembered her granddaughter's birthday without being reminded. Because the woman her daughter thought she was losing had walked back through the door. She did not have dementia. She had drug-induced cognitive impairment for medications that were silently blocking a critical brain chemical. And she had been 1 referral away from a memory care facility. That story is not rare. It is happening right now in homes and clinics and care facilities across the country, in numbers that should be making headlines. And it is almost never being caught, because the symptoms look exactly like real dementia, because the medications causing them are considered routine, and because almost nobody is making the connection between what is in the pill bottle and what is happening inside the brain. My name is Dr. William Madison. I have been in clinical practice for more than 20 years, and today I'm going to walk you through 9 medications that research has directly linked to memory loss, cognitive decline, and in some cases, conditions that look so much like dementia that even specialists have difficulty telling them apart. Some of these medications are prescription drugs your doctor recommended. Some are things you can buy right now without a prescription. All 9 of them are taken regularly by millions of older adults who have no idea what they may be doing to the brain. I need to say something clearly before we go any further. I am not telling you to stop any medication on your own. Please do not do that. Some of these drugs require careful, gradual tapering under medical supervision, and stopping them suddenly can cause serious harm. What I am doing today is giving you the information you need to have a real, specific, informed conversation with your doctor about whether every medication you are currently taking is still the right choice for your brain. Stay with me through all 9, because the one at the top of this list is not a single medication. It is something happening in the medicine cabinets of millions of older adults right now, silently and without any warning, that researchers have found more than doubles the risk of dementia over 10 years. And almost nobody is talking about it. Let us start at number 9. There is a pink pill that sits in medicine cabinets and bedside drawers in almost every home in the country. You have probably taken it at some point, maybe last week, maybe last night. It is sold under many names, but the active ingredient is diphenhydramine. Most people know it as Benadryl. It is available without a prescription at any pharmacy, any supermarket, any petrol station. People take it for allergies, for cold symptoms, and very commonly as a sleep aid. The label says it is safe. The price is low. The availability is total. And for an aging brain, it may be one of the most quietly harmful substances you can take on a regular basis. Here is why. Deep in your brain, a chemical called acetylcholine carries messages between brain cells. It is involved in forming new memories, staying alert and focused, and keeping thinking clear. As you get older, your brain naturally produces less acetylcholine than it once did. That is a normal part of aging. The problem comes when you take a medication that actively blocks what little acetylcholine your aging brain still has available. Diphenhydramine belongs to a class of drugs called anticholinergics. Blocking acetylcholine is not a side effect of how this drug works. It is the mechanism. That is how it makes you drowsy. And that same mechanism, applied to an aging brain repeatedly over months and years, interferes with the brain region responsible for forming and storing new memories. A study published in a leading journal of geriatric medicine found that older adults who used anticholinergic drugs regularly had a 54% higher risk of developing dementia compared to those who avoided them. 54%. From a pill most people consider completely harmless because it does not require a prescription. The next time you reach for a sleep aid or allergy tablet, check the label for diphenhydramine. If it is there, it is an anticholinergic. For allergies, newer, non-sedating options like loratadine do not cross into the brain the same way and are considered dramatically safer for older adults. For sleep, there are better options we will discuss. But diphenhydramine, as a regular sleep solution for someone over 60, is something worth raising urgently with your doctor. Number 8 is one that millions of people take every morning as faithfully as they drink their coffee. And the conversation I am about to have with you about it is one that almost never happens in a standard medical appointment. Proton pump inhibitors. You know them as omeprazole, pantoprazole, lansoprazole. Medications prescribed for heartburn, acid reflux, and stomach protection. They are among the most commonly prescribed drugs in the world, and many people have been on them for years, sometimes for decades, because the symptoms come back the moment they stop. The brain connection happens through a nutrient, specifically vitamin B12. Your stomach produces acid for many reasons, and one of them is that acid is required to absorb vitamin B12 from the food you eat. When these medications suppress stomach acid long-term, B12 absorption drops. And B12 is not optional for brain health. It is essential for protecting the protective coating around nerve fibers. It is involved in the production of neurotransmitters, the chemicals that carry messages between brain cells. When B12 falls low enough, the result can look remarkably like early dementia, memory problems, mental fog, difficulty concentrating, emotional changes. A major study examining over 73,000 adults aged 75 and older found that regular users of these stomach acid medications had a 44% increased risk of developing dementia compared to non-users. The research also shows that these drugs may increase levels of amyloid beta proteins in the brain. These are the toxic proteins that build up in Alzheimer's disease and are considered one of its core drivers. If you have been taking one of these medications for months or years, I want you to do something specific. At your next doctor's appointment, ask whether you still need it, and at what dose, and whether your vitamin B12 level has been checked recently. Ask whether there are lifestyle changes or different treatments that could address the underlying reflux without long-term acid suppression. Do not stop it on your own, but do not continue it indefinitely without a current, specific reason that has been reviewed with your doctor. Number 7 is a medication that addresses a very real and very distressing problem. And I want to approach this one with care, because bladder control issues cause genuine difficulty and embarrassment for many older adults and deserve real treatment. But the most commonly prescribed medication for this problem has a brain safety profile that most patients are never told about. Oxybutynin, sold under the brand name Ditropan, is one of the most frequently prescribed medications for overactive bladder and urinary incontinence in older adults. And like diphenhydramine, it is an anticholinergic. It works by blocking acetylcholine in the bladder muscles to reduce urgency and frequency. But acetylcholine is everywhere in the body, including throughout the brain. And oxybutynin crosses very easily from the bloodstream into the brain, where it blocks the same memory-related chemical signals as the sleep aid we just discussed. A comprehensive study published in the British Medical Journal found that people over 65 who took strong anticholinergic medications like oxybutynin for more than 1 year had a 49% higher risk of developing dementia. Nearly half again the normal risk, from a medication prescribed for something that seems entirely unrelated to the brain. The cruelty of this is that the symptoms it causes often get misattributed. People notice they are more forgetful. They struggle to follow conversations. They lose track of where they put things. And they, and often their doctors, assume this is just aging. The connection back to the medication is rarely made until significant time has passed. Here is the important part. You do not have to choose between bladder control and brain protection. Newer medications for overactive bladder, like mirabegron, work through a completely different mechanism and do not block acetylcholine. They have shown significantly less impact on cognitive function and are considered much safer for older adults. If you are currently taking oxybutynin and you have noticed any changes in memory or thinking, please bring that directly to your doctor and ask about alternatives. This is a solvable problem. Number 6 is the most widely prescribed medication category in the world for adults over 60. And I want to be very precise about what I am and am not saying here, because this one requires genuine nuance. Statins. Simvastatin, atorvastatin, rosuvastatin. Medications prescribed to lower cholesterol and reduce the risk of heart attacks and strokes. The cardiovascular evidence for statins in people with existing heart disease is solid and well established. I am not telling you to stop your statin. What I am telling you is this. Cholesterol is not simply a heart health number. Your brain is made up of nearly 60% fat, and cholesterol is a critical component of myelin, the protective coating around nerve fibers that allows brain signals to travel quickly and accurately. When cholesterol is lowered significantly and rapidly, especially with high-dose statins, some people experience cognitive effects, memory problems, mental fog, word-finding difficulties, confusion on familiar routes. A study published in Frontiers in Aging Neuroscience found that adults over 70 who had been taking statins for more than 3 years had a 26% higher risk of mild cognitive impairment. Those on higher doses showed more pronounced cognitive changes. Not all statins cross into the brain equally. Simvastatin and atorvastatin are fat-soluble and enter brain tissue more easily. Pravastatin and rosuvastatin are water-soluble and cross the blood-brain barrier much less readily, making them generally considered less risky for cognitive function. If you are on a statin and you have noticed increasing mental fog, more difficulty remembering things, or confusion that was not there before you started the medication, that is worth discussing specifically with your doctor. Ask which statin you are on and whether switching to a water-soluble version might make sense given your cardiovascular risk profile. Ask whether your current dose is the minimum effective dose. These are reasonable, important questions that deserve a real answer. Number 5 is a medication that many people initially feel saved them, and which over time becomes something they cannot seem to live without, while quietly taking something irreplaceable in return. Benzodiazepines. Lorazepam, diazepam, alprazolam. Sold as Ativan, Valium, and Xanax. Prescribed for anxiety and sleep problems, these medications work by enhancing a calming chemical in the brain called GABA. They quiet racing thoughts. They ease panic. They allow sleep to come. In a crisis, they can feel like genuine relief. But over time, something changes. A study published in the British Medical Journal followed more than 8,000 older adults for 6 years and found that those who had used benzodiazepines for more than 3 months had a 51% increased risk of developing Alzheimer's disease. The risk was even higher for the long-acting versions, like diazepam, which stay in the body and accumulate in brain tissue over time. Here is the mechanism in plain language. These medications slow neural activity throughout the brain. They make it quieter. At first, that feels like calm. Over months and years, the brain becomes less flexible, less efficient, slower to form new memories, slower to process information. People describe feeling like they are moving through a fog, like their personality has become muted, like they are present but not fully there. And then when they try to stop the medication, withdrawal produces the very symptoms it was supposed to treat: severe anxiety and crushing insomnia, so intense that stopping feels impossible. The drug has created the dependence that makes it feel essential. If you have been on a benzodiazepine for more than a few weeks, do not stop it suddenly. This is genuinely dangerous and requires careful medical supervision. But please, have an honest conversation with your doctor about a gradual tapering plan. There are safer alternatives for anxiety, including a medication called buspirone that does not carry the same cognitive risks. For sleep, cognitive behavioral therapy for insomnia has actually been shown in research to outperform medication for long-term sleep quality. These are real options that your doctor may not have raised, and they are worth asking about specifically. Number 4 is an older antidepressant that is still prescribed far more widely than most people realize. Not just for depression, but for nerve pain, migraines, and sleep problems. It is considered versatile and inexpensive, and it is one of the most potent anticholinergic medications still in common use today. Amitriptyline, sold as Elavil. If you have been paying attention through the earlier part of this conversation, you already understand why an anticholinergic medication is a particular concern for the aging brain. Amitriptyline blocks acetylcholine so powerfully that cognitive effects are not a rare or unlikely side effect. They are a predictable consequence of long-term use. A major study published in JAMA Internal Medicine examined more than 3,400 adults aged 65 and older over a 10-year period. It found that those who took higher cumulative doses of anticholinergic medications like amitriptyline had a 54% greater chance of developing dementia. The damage does not require high doses. Even a low dose taken nightly for several years can create a slow, invisible erosion of brain function that is easily mistaken for the natural progression of aging. Patients taking this medication commonly describe word-finding difficulty, the frustrating experience of knowing what you want to say but being unable to retrieve the word. Short-term memory lapses, increasing confusion, a general slowing of thinking that comes on gradually enough that it is attributed to getting older rather than to the medication. If you are taking amitriptyline for nerve pain, there are alternatives. Duloxetine and gabapentin address nerve pain through mechanisms that do not involve blocking acetylcholine. For sleep, melatonin and behavioral approaches carry far less cognitive risk. For mood support, newer antidepressants like sertraline and escitalopram are generally considered significantly safer for brain health in older adults. Please ask your doctor about these options specifically. Number 3 is going to require me to make a distinction that is critically important. Because the drug I am about to discuss is classified as a modern antidepressant, the same category as several of the safer alternatives I just mentioned. And most people taking it have no idea it is fundamentally different from its relatives in a way that directly affects brain safety. Paroxetine, sold as Paxil. Most antidepressants in the SSRI class are considered relatively safe for cognitive function in older adults. But paroxetine is the exception within that category. It is the only SSRI with significant anticholinergic properties. That one difference changes everything about its brain safety profile. A large review examining the cognitive effects of different antidepressants in elderly patients found that paroxetine users showed measurable declines in short-term memory, verbal recall, and attention span within the first 12 months of treatment. Seniors taking paroxetine were 30% more likely to show early warning signs of cognitive impairment compared to those taking other antidepressants. The American Geriatric Society has placed paroxetine on its Beers criteria list, which is a carefully compiled list of medications considered potentially inappropriate for older adults due to safety concerns. That is an official, medical, evidence-based designation. It is not a fringe opinion. If you are currently taking paroxetine for depression or anxiety, please ask your doctor about switching to sertraline or escitalopram. These medications work through the same basic mechanism. They are in the same drug class, but they do not carry the same anticholinergic burden. In most cases, a gradual switch can be made without disrupting the treatment of the underlying condition you need help with, while significantly reducing the cognitive risk. Number 2 is the one on this list that I find most troubling from a systemic perspective. Not because of the medications themselves, which were designed for genuinely serious conditions, but because of how widely they are now being used in older adults, for reasons that have nothing to do with what they were created for. Antipsychotics. Quetiapine, risperidone, olanzapine, sold as Seroquel, Risperdal, and Zyprexa. These are powerful psychiatric medications developed to treat schizophrenia and severe bipolar disorder. They have an important role in those conditions. But today, they are being prescribed off-label to large numbers of older adults in nursing homes, and sometimes at home, for restlessness, agitation, sleep problems, and behavioral changes associated with dementia. In other words, they are frequently being used not because the patient has schizophrenia, but because the patient is confused, difficult to manage, or keeps staff awake at night. The consequences of this are severe and well documented. A comprehensive study published in the Lancet Healthy Longevity followed more than 25,000 older adults and found that seniors prescribed antipsychotics for behavioral symptoms were 71% more likely to experience worsening cognitive decline within 12 months, even if they had no prior diagnosis of dementia before starting the medication. These drugs also significantly increase the risk of stroke, dangerous heart rhythms, falls, and sudden cardiac death in older adults. The FDA has required a black box warning on these medications, specifically regarding their use in elderly patients with dementia-related behavioral problems. The mechanism behind the cognitive damage is direct. These medications work by suppressing dopamine. Dopamine is not just involved in mood and motivation. It is essential for memory processing, decision-making, and executive function. When dopamine is suppressed in an older brain, the result is often exactly what families witness but do not understand. A person who seems to fade, whose eyes lose their spark, whose personality becomes flat and muted, whose family members describe grieving for someone who is physically still present. If someone you love is in a care facility and is taking one of these medications, you have every right to ask why. Ask what specific condition it was prescribed for. Ask whether non-medication approaches to managing their behavior have been genuinely tried. Ask what the exit plan is, because these medications should not be indefinite. Behavioral symptoms in older adults can very often be managed through environmental changes, structured routines, addressing underlying pain, improving lighting and sleep conditions. Medication should be the last option, at the lowest possible dose, for the shortest possible time. Not the first tool reached for because it is convenient. And now we arrive at number 1. I told you at the beginning that the most dangerous thing on this list is not a single medication. And I want you to understand why, because this is the piece of information that has the most power to protect you or someone you love right now. The number 1 hidden threat to brain health in older adults is what happens when multiple medications with anticholinergic properties are taken together at the same time. Doctors call this anticholinergic polypharmacy. And most patients taking these medication combinations have no idea it is happening because nobody has ever added up the total burden of what they are taking. Let me give you a picture of how this looks in a real household. An older adult takes diphenhydramine every night to help sleep. They take oxybutynin every day for bladder control. And they take amitriptyline every evening for nerve pain in their feet. Each of these medications carries its own anticholinergic load. Each one alone would be a concern. Together, they are not simply adding up. They are multiplying. A major analysis published in Age and Aging tracked more than 280,000 older adults and found that those with the highest combined anticholinergic burden had a 120% increased risk of developing dementia over 10 years. That is more than double the normal risk. Not from a single dangerous drug. From 3 medications that each seemed reasonable on their own, prescribed at different times by different doctors, with nobody ever looking at the total picture. 120% increased risk. From a combination that is sitting right now in the medicine cabinets of millions of people who have no idea. And here's what makes this simultaneously devastating and genuinely hopeful. Drug-induced cognitive impairment from anticholinergic medications is often reversible. When the medications are identified and removed, slowly and carefully under medical supervision, many people experience a genuine and significant recovery of mental function. The brain, when given the chance, can recover from this kind of chemical suppression in ways it cannot recover from true Alzheimer's disease. The woman I told you about at the beginning of this video did not have dementia. She had a treatable, reversible, medication-caused condition that had been building silently for 18 months. And when the cause was removed, she came back. How many people right now are being assessed for memory care placement when the real cause of their cognitive decline is 3 medications that no one has looked at together? How many families are grieving someone they have not lost, while the thing causing the loss sits in a pill organizer on the kitchen counter? This is why medication review matters, not as a bureaucratic checklist, as a genuine, life-changing clinical conversation. Here is exactly what I want you to do after you finish reading this. Write down every single thing you take, every prescription, every over-the-counter medication, every supplement, every vitamin, everything. Be thorough. Include the sleep aids and the allergy tablets and the antacids, not just the prescriptions. Look through that list for the following types of medications. Older antihistamines or sleep aids containing diphenhydramine, stomach acid medications like omeprazole or pantoprazole, bladder control medications especially oxybutynin, statins especially simvastatin and atorvastatin, any benzodiazepine including lorazepam, diazepam, and alprazolam, the antidepressant amitriptyline, the antidepressant paroxetine or Paxil, and any antipsychotic medication. If you see any of these on your list, that is not a reason to stop the medication. It is a reason to have a specific, informed conversation with your doctor at your next appointment. Here's what to say. You can bring this list with you and read it directly if that is easier. Say, I have been learning about the cognitive effects of certain medications in older adults, and I would like to review my current medications with you. I am specifically interested in whether any of what I am taking carries anticholinergic properties and what the total combined burden of my medications looks like for my brain. I want to understand whether there are safer alternatives for any of them. A good doctor will welcome this conversation. They may not have had the time to review your medications through this lens at previous appointments. They may not have been the one who prescribed some of these drugs. But when you bring the question directly and specifically, you make it possible for that review to happen. If your doctor is not familiar with the concept of anticholinergic burden, ask for a referral to a geriatric pharmacist or a geriatrician. These are specialists who focus specifically on medication management in older adults, and a comprehensive medication review with one of them could be one of the most valuable medical appointments you will ever have. There is also a question you can ask your pharmacist, who is often underused as a resource for exactly this kind of review. Ask them whether any of your current medications have anticholinergic properties, and what the combined burden of your medication list looks like. Pharmacists have access to tools that calculate this, and many of them are glad to be asked. Let me tell you what I hope you take from this video. Your brain is not simply aging on a fixed and inevitable schedule. The sharpness, the clarity, the memory, the ability to follow a thought from beginning to end and find the word you are looking for, these are not simply fading because time is passing. For many older adults, they are being affected by something external, something chemical, something that can be identified and in many cases corrected. The woman who came into my clinic with her daughter had been told by well-meaning people who loved her that this was just aging, that they needed to plan for what came next, that the person she had been was leaving. She was not leaving. She was being medicated into a shadow of herself, and when the medication was removed, she came back. I cannot promise that everyone's story will look like hers. Genuine dementia is real, and for people with true Alzheimer's disease or other progressive dementias, medication changes will not reverse what is happening. But for the people whose cognitive decline is being driven or worsened by the medications they trust completely, the opportunity for recovery is real. And it begins with the conversation that most people never knew to have. If this gave you something today, if you heard the name of a medication you were taking and felt something shift in your understanding, please do not sit with that alone. Write the question down, bring it to your doctor, ask it clearly and by name. You are entitled to know what every medication you take is doing inside your brain. And if someone you care about is taking any of the medications on this list, please share this with them. A parent who has been more forgetful lately. A friend who described feeling foggy after starting a new prescription. A spouse whose thinking has changed in a way that everyone has been quietly accepting as inevitable aging. The information that changes an outcome is only valuable when it reaches the person who needs it, before it is too late to matter. I'm Dr. William Madison. Your mind is worth protecting with the same urgency as your heart. Take care of yourself, take care of the people around you, and I will see you in the next video.